Good morning, everyone. I am Dr. ANUSREE, practicing periodontist and implantologist. I've completed my post-graduation from Royal Dental College, Palakkad. Today, we'll be discussing Section 4 of Misch Contemporary Implant Dentistry as a part of the reading club conducted under the GCOI International Implant Summit 2026, and we will begin with Chapter 15, Interactive Computer Tomography and Dental Implant Treatment Planning. Fabrication of radiographic template. In the literature, there exists significant confusion in the use of prosthodontic terminology and nomenclature when describing radiographic and surgical templates. The terms stent, guide, model, and appliance have been used interchangeably in the description of these processes. Additional terms sometimes used in identifying these processes include scan appliance, scan stent, radiographic or surgical appliance, and radio-opaque appliance. However, according to the Journal of Prosthetic Dentistry, Glossary of Prosthodontic Terms, the definition of template best describes the purpose of the processes. Prosthodontic Glossary of Terms. Template. It's a thin, transparent form duplicating the tissue surface of a dental processes and used as a guide for surgically shaping the alveolar process. A guide used to assist in proper surgical placement and angulation of dental implants. Stent. It is named for a dentist who first described their use. Charles R. Stent. Such ancillary processes are used to apply pressure to soft tissue to facilitate healing. Appliance, a device or restoration, something developed by the application of ideas or principles that are designed to serve a special purpose or perform a special function. A broad term applied to any material or processes that restore or replace lost tooth structure, teeth, or oral tissue. A model, it's a facsimile used for display purpose, a miniature representation of something. A guide, no definition exists in the prosthodontic glossary of terms. Moving to surgical restriction templates. First one is a non-limiting design. A non-limiting surgical template is a template that allows for a generalized location of the ideal implant site. No actual directional guide is built into this type of template other than possibly the buccal or lingual contour of the ideal positioning of the teeth. A simple and inexpensive method to fabricate this type of template is duplication of an existing processes or modification of Preston's clear splint for the diagnosis of tooth contour, tooth position, and occlusal form. Second one is the partial limiting design. The partial limiting design incorporates a guided sleeve or a slot that allow for angulation of one drill size, usually the pilot drill. Therefore, after the first drill is used, the remainder of the osteotomy sites are completed freehand. Various techniques can be used, including manual laboratory fabricated template or template fabricated from a radiographic template, which is then converted into a surgical guide template. Next is the CBCT template by support. When using a CBCT generated treatment plan, the complete limited design is the most common. There are three types of CBCT supported guides, that is tooth supported, bone supported, or tissue supported. First one is a tooth supported guides. The tooth supported guide are the most accurate and easiest guide to use. These guides are mainly used in partially edentulous patients and are highly dependent on the accuracy of the impression and study cast. This guide typically are translucent, thus allowing visualization of the complete seating of the guide. No gap should be present between the guide and the teeth on the study cast or in the mouth. In addition, the guide must be stable and have no movement when lightly manipulated. Then moving to the indications, it's used for partially edentulous patients. Second one is a sufficient number of teeth for guide support. Requirements: study cast plus CBCT, stereolithography, file of study cast plus CBCT, digital impression, and plus CBCT. Moving to bone supported guide. Bone supported guide may be used in partially or fully edentulous patients. These guide require extensive full thickness reflection to expose the bony ridges to allow proper seating of the guide. If bone modification is indicated, proper seating of the guide may be difficult, resulting in error in implant placement. In some cases, a bone reducing guide may be used before seating the bone supported guide. It should be noted that small bone protuberance may exist that are below the resolution of the scan. Therefore, meticulous evaluation of the bone contour should be evaluated before osteotomy site preparation. Moving to indications, used in edentulous patients, partially edentulous patients. Next, the soft tissue supported guide. Soft tissue supported guide are usually indicated for completely edentulous patients, and these surgeries are usually termed flapless. In some cases, the guides are difficult to seat correctly, especially if there exists overextension beyond the vestibule or floor of mouth. Bite registration are sometimes used to ensure ideal placement positioning. In many cases, stabilizing the pin or screws are placed to improve stability during osteotomy and implant placement. The most challenging case for the use of soft tissue guide are the maxilla with flat palatal walls and mandible with high floor of the mouth with very little vestibule. Most full arch soft tissue supported guides are fabricated by the dual scan technique. Indications: only edentulous patients. Second one is must have sufficient support. In maxilla, it's the palate. In mandible, sufficient vestibular or lingual support of the prosthesis. Surgical template complications. Overheating the bone. Because of the tolerance between the drill size and the surgical template tube, inadequate irrigation often results. It is imperative to use as much irrigation as possible to prevent this complication. This may involve the use of supplemental irrigation in the form of external irrigation. In most templates, the facial aspect may be altered, which allow for the delivery of additional saline solution. Second one is the bone dance. As bone dance preparation is most important in better quality bone D1 or D2. Bone dancing include preparing the osteotomy in a pumping motion, which allow irrigation to enter into the template tube and osteotomy. Third one is refrigerate irrigation. Barak et al. Showed that cooling the irrigation fluid to 10 degrees Celsius is a safe method for implant site preparation and drilling through a drilling guide in the terms of temperature control. These results showed no mean increase in the temperature, and therefore the sterile saline irrigation fluid may be stored in a refrigerator before surgical procedure. Second one, inadequate access. A common complication with surgical template may exist with posterior implant placement because most guided drills are longer than standard surgical drills. In many cases, the clinician may not have sufficient intra-arch space to drill the osteotomies. In addition, most tubes are used in surgical templates are approximately 5 mm in height, which further increase the difficulty in drill access. Many surgical template manufacturers may fabricate buccal or lingual access within the guide, which allows the clinician a greater access. Next one is difficulty in template seating. With bone-supported guide, many clinicians may have difficulty in seating the template because of the extent of required reflection. It is imperative that the template seat completely on bone and no soft tissue prevents the seating. Therefore, the incision and reflection should be pre-planned to accommodate the size and peripheral extent of the surgical template. Next, we are moving to chapter 16, that is available bone and dental implant treatment plans. This chapter will describe the three-dimensional concept of available bone and the implant treatment options for each type of bone anatomy. Here, figure 16.3 denotes a Legholm and Zapp classification of bone volume in 1985 for residual jaw morphology. It's related to insertion of Brennemark fixture. They describe 5 stages of jaw resorption ranging from minimal to extreme. So, to understand the available bone classification, the clinician must have a knowledge of dental implant size, that is width or diameter, and height or length of an implant. Moving to implant diameter or implant width. Figure 16.5 denotes a tapered dental implant showing width and length along with distinct difference between crest diameter and body. For a generic cylinder root form implant design, each 0.25 mm increase in diameter corresponds to a surface area increase of approximately 5 to 8%. Therefore, a cylinder root form implant 1 mm greater in diameter will have a total surface area increase of approximately 20 to 30%. Because stress equals force divided by functional area over which it is applied. The greater diameter decreases the amount of stress at the crestal bone implant interface. Because early bone loss relate to the crestal bone region and prosthetic complications may be related to the crest module size of an implant. The width of the implant is much more critical than its height after a minimum height has been obtained. Moving to implant height. The height of an implant also affects the total surface area. A cylinder root form implant 3 mm longer provides a 20 to 30% increase in surface area. The advantage of increased height does not express itself at the crestal bone interface, but rather in initial stability of the implant, the overall amount of bone implant interface, and a greater resistance to rotational torque during abutment screw tightening. The minimum height for a long-term survival of endosteal implant is in par related to the density of bone. The denser bone may accommodate a shorter implant, and the least dense weak bone require a longer implant. After the minimum implant height is established for each implant design and bone density, the width is more important than additional length. This chapter primarily presents the volume of bone requirements for ideal bone density situations, or D2, which is coarse tubercular bone surrounded by a porous to dense cortical bone. Available bone height. The height of available bone is measured from the crest of the edentulous ridge to the opposing landmark. The anterior region are limited by the maxillary nares or the inferior border of the mandible. Usually, the anterior region of the jaw have the greatest height because the maxillary sinus and inferior alveolar nerve limit this dimension in the posterior region. The maxillary canine eminence region often offers the greatest height of an available bone in the maxillary anterior. In the posterior jaw region, there is usually greater bone height in the maxillary first premolar than in the second premolar, which has greater height than the molar side because of the concave morphology of the maxillary sinus flow. Next is the available bone length. The mesiodistal length of available bone in an edentulous area is often limited by adjacent teeth or implant. As a general rule, the implant should be at least 1.5 mm from the adjacent tooth and 3 mm from an adjacent implant. Therefore, in case of a single tooth replacement, the minimum length of available bone necessary for an endosteal implant depends on the width of the implant. For example, a 5 mm diameter implant should have at least 8 mm of mesiodistal bone, so a minimum of 1.5 mm is present on the buccal and 1 mm on the lingual. A minimum mesiodistal length of 7 mm is usually sufficient for a 4 mm diameter implant. Of course, the diameter of the implant is also related to the width of available bone and in multiple adjacent sites is primarily limited in this dimension. For example, a width of bone of 5 mm without augmentation require a 3.5 mm or smaller implant with inherent compromise, such as minimal surface area and greater crestal stress concentration under occlusal load. Therefore, in the narrow ridge, it is often indicated to place 2 or more narrow diameter implant when possible to obtain sufficient implant bone surface area to compensate for the deficiency in width of the implant, because the implant should be 3 mm apart and 1.5 mm from each tooth, 13 mm or more, that is 3.5 mm plus 3.5 mm plus 3 mm between implants plus 1.5 mm plus 1.5 mm from adjacent teeth. In available bone mesiodistal length, it may be required when the narrower implant dimensions are used to replace a posterior tooth. Moving to divisions of available bone. Division A, abundant bone. Division A dimensions given in box number 16.1. Here, width is greater than 7, height is greater than 10 mm, mesiodistal length is greater than 7 mm, angulation of occlusal load between occlusal plane and implant is less than 25 degree, crown height space is greater than crown height space is less than or equal to 15 mm, and prosthesis fixed, that is FP1, likely possibly FP2, removable, that can be RP4 or RP5. Moving to box 16.3, that is division B dimensions. Division B, it offers sufficient available bone height with compromised width. So division B is further classified into a ridge of 4 to 7 mm width and B minus width, that is of 2.5 to 4 mm, height greater than 10 mm, mesiodistal length of greater than 6 mm, angulation less than of 20 degree, crown height space less than 15 mm, and prosthesis in fixed, it is most likely FP2 or FP3, and removable, it can be RP4 or RP5. And there are 3 treatment options are available for the Division B edentulous ridge. One is to modify the existing Division B ridge to Division A by osteoplasty to permit the placement of root form implants 4 mm or greater in width. When more than 10 mm of bone height results, the bone convert to Division A. When less than 10 mm of bone height results, the bone convert to Division C minus H. Second one is to insert a narrow Division B root form implant. And third one is to modify the existing Division B bone to a Division A by bone augmentation. Moving to Division C, compromised bone, box 16.5 denotes Division C bone. Here width as Division C minus width of the bone 0 to 2.5 mm, height, that is Division C minus height of the bone, and angulation of occlusal load is greater than 30 degree, crown height space is greater than 15 mm, and prosthesis and fixed, it is most likely FP2 or FP3, in removable ideally RP5 because of increased crown height space. Moving to Division C treatment options, one is osteoplasty, second one is root form implant, third one augmentation procedure before implant insertion, fourth one subperiosteal implant, and fifth one disc implants. Next is Division D bone that denotes severe atrophy. So Division D bone in box 16.7 denotes severe atrophy, basal bone loss, flat maxilla, flared maxillary anterior, pencil thin mandible, greater than 20 mm crown height prosthesis, and fixed, that is FP3, while removable it is ideally RP5 because of increased crown height space. Moving to Chapter 17, Prosthetic Option in Implant Dentistry. Main advantages of removable implant-supported prostheses in completely edentulous patients are: facial aesthetics can be enhanced with labial flanges and denture teeth compared with customized metal or porcelain teeth. The labial contour of the removable restoration can replace lost bone width and height and support the labial soft tissue without hygienic compromise. The prosthesis can be removed at night to manage nocturnal parafunction. Fewer implants may be required. Less bone augmentation may be necessary before implant insertion. Shorter treatment if no bone augmentation is required. Treatment may be less expensive for the patient. Long-term treatment of complications is facilitated. Daily home care is easier. Repairs are much easier than with a fixed prosthesis. Next is the advantages of fixed restoration in the completely edentulous patients. Greater masticatory force, greater patient satisfaction, psychological, less food entrapment, less maintenance, longevity, and possible overhead cost as completely implant-supported overdentures. Table 17.1 denotes the prosthodontic classification. Types are FP1, that is fixed prosthesis that replace only the clinical crown, looks like a natural tooth. FP2, its fixed prosthesis, replaces the crown and portion of root. Crown contour appear normal in the occlusal half but is elongated or hypercontoured in the gingival half. FP3, fixed prosthesis, replaces missing crown and gingival color and portion of edentulous side. Prosthesis most often uses denture teeth and acrylic gingiva but may be porcelain to metal or zirconia. RP4, removable prosthesis, overdenture that is completely implant supported, no soft tissue support. RP5, removable prosthesis, overdenture supported by both soft tissue and implant. The primary stress bearing area are maintained in the prosthesis. Mainly in the maxilla, it is the residual ridge and horizontal palate, and in the mandible, it is the buccal shelf area. Moving to prosthetic options. In 1989, Misch proposed 5 prosthetic options for implant dentistry. The first 3 options are FPs, that is FP1, FP2 and FP3. These 3 options may replace partial, that is one tooth or several, or total dentition, and may be cemented or screw retained. They are used to communicate the appearance of final prosthesis to all of the implant team member and the patient. These options depend on the amount of hard and soft tissue structure replaced and the aspects of the prosthesis in the aesthetic zone. Common to all fixed options is the inability of the patient to remove the prosthesis. Two types of final removable implant restorations are RPs, that is RP4 and RP5. They depend on the amount of implant and soft tissue support, not the appearance of prosthesis. Figure 17.19 represent fixed restoration have three categories, that is FP1, FP2 and FP3. Restoration type is related to the contour of the restoration. FP1 is ideal, FP2 it is hypercontoured, FP3 it replaces the gingiva drape with pink porcelain or acrylic. The difference between FP2 and FP3 most often is related to the high maxillary lip position during smiling or the mandibular lip position during sibilant sound of speech. FP2 and FP3 restorations are most often require more implant surface area supported by increasing implant number or size or by adjusting design considerations. And with this, we come to the conclusion of this session. Thank you.